gentlemen. This is Dr. Harsh Chaturvedi. I represent medical affairs and clinical research of Pulse Pharmaceuticals, which is based at Hyderabad and is known for innovation in the pharmaceutical world. Today, we are here to learn and understand more about managing the osteoporotic fractures under the auspices of Pulse D-National Conclave. Before I go on to hand over the academic session to Dr. Thakkar and the animal personnel panelists, I would briefly like to say that osteoporosis, we all know, is a very common brittle bone disease, and fragility fractures, which occur spontaneously or after low energy trauma, are a complication of progressive loss in bone mass and the changes in the microarchitecture. The most common we know are the sites which are vertebra, wrist, and the proximal femur. Well, it is estimated that one out of every two women will have a fracture between menopause and the end of life. After 80 years of age, 70% of the women have osteoporosis and 60% have one or more fractures. Osteoporotic fractures are not limited to women. Men also have, though it is less common in men, but they have more serious fractures and more serious consequences. And because of very high prevalence and significant morbidity and additional mortality and the socioeconomic consequences, osteoporosis we know is a public health concern for all physicians, especially for surgeons who are treating a patient at the time of fracture. Yet, surprisingly, osteoporosis is too often a disease that is trivialized and lumped into the aging phenomena, which leads to insufficient diagnosis and treatment. Today, ladies and gentlemen, we are very fortunate to have a very eminent panel discussing on the various facets of osteoporosis and the osteoporotic fractures. I'll briefly take time. I know none of them needs any introduction, but I would like to speak a few lines about each one of them. And just give me a minute. I'll put my slides on. I'll share my slide screen, and I hope my screen is visible to everybody. So,
Yes, it is.
yeah, ladies and gentlemen, I welcome you again in Pulse D National Conclave. We have with us Dr. DILIP TANNA, Dr. JAWAHAR T JETHWA, and Dr. NAVIN THAKKAR. And I'm sure none of these individuals, they need any introduction. But since it's a customer, I'll try to read a few lines. First, about Professor Tanna. His colleagues have said that to be with him every time is fresh knowledge, exciting learning, aspiration, motivation, and blessings. I don't know what further to say, but yet I have put on a few lines. He is retired from Topiwala National Medical College and BYL Nair Charitable Hospital in Mumbai and is currently consultant to many corporate hospitals. Professor Tanna has over 50 years of experience and is reputed for his expertise in revision trauma surgery, and his other interests include complex trauma management, failed fracture treatment, and joint replacement surgery. Dr. Tanna is a prolific writer with his seminal work include Tanna's interlocking book, Orthopaedic Tidbits, Orthopedic Secrets, and Proximal Femur Fracture. Dr. Tanna is Honorary Fellow of Indian Orthopaedic Association and recipient of the Lifetime Achievement Award from Trauma Society in All India Orthopaedic Association. With these words, I welcome you, Professor Tanna, and I must add, we are privileged to have you with us. I'm sure many of us are going to learn a lot more about osteoporosis and osteoporotic fractures from you. We look forward to it, sir. We also have the pleasure of having Dr. JAWAHAR T JETHWA, who is the past president of Ahmedabad Orthopaedic Society and Gujarat Orthopaedic Association. He is an executive member, committee member of Indian Orthopaedic Association. Dr. Jethwa is faculty for National Trauma Management course. He is in charge of the IT and Web Committee of Indian Orthopaedic Association. Dr. Tanna is known for having developed the first video-based medical practice software in the year 1996. He is a recipient of SP Mandal Orthopedic Gold Medal in 2017 for his research on innovative implants. He is a recipient of Best Paper Award for the work on osteosynthesis by epoxy resins. He indigenously designed new external fixator, shaping press, JJ compression clip, and many other things, including Ahmedabad bolt and Gujarat guide. He is chief medical researcher and advisor on drug-eluting orthopedic implants and has been a speaker at many conclaves. He has conducted numerous workshops, presented papers, published articles, and including a chapter in the fifth edition of Professor Tanna's interlocking book. With these words, I welcome you, Dr. Jethwa, to this gathering. And
Dr. Harsh, you changed the slide. It is in the reading mode. Now it is okay.
yeah, sir, my other mode. Okay. So now we have, last but not the least, we have the moderator for today's evening, Dr.
Again, you
Navin
have to
Thakkar.
change the slide. Again, you will need to change the slide because you are in the reading mode. You have not clicked the PowerPoint. So yeah, that was the problem. Okay, go back.
Okay.
Very good.
Okay. Uh,
No problem.
Dr. Thakkar is the past president of Gujarat Orthopaedic Association and past Secretary General of IOA. He has been a recipient of Shushrat Award in IOCON 2006. He was awarded for Innovator Gold Medal by the Inventors of India Meet in 2006 at IIM Ahmedabad. He is a recipient of KT Dolakia Gold Medal, IOCON 2007, SP Mandal National Orthopedic Gold Medal at IOCON 2008, a gold medal at NailsCon in 2012. He has been awarded the Silver Jubilee Oration Award of IOCON in 2012. He's been IOCON Conference Oration in 2016, Presidential Appreciation Award for dedication to IOA activities in IOCON 2016 again, and he's the first Indian orthopedic surgeon to get 2 US patents. Furthermore, he worked for IOA website. He developed and he ensured transparent online elections. With these words, I welcome you, Dr. Thakkar, to this meeting. This about concludes my introductory slides. I'll request my colleagues to play the corporate video before we start with Dr. Thakkar as he takes us on this academic session. Hello, can I have the corporate video, please?
Yeah, he has said already. Alok has said.
Pulse, a true reflection of the heart and its functioning. A heart that is compassionate about others and passionate about its work. A heart that is dynamic yet consistent. A heart that is predictable and reliable. A heart that goes the extra mile to deliver what is expected. Our business philosophy encompasses these very principles. At Pulse Pharma, we feel patients' problems, think, innovate, and do everything that it takes to deliver cost-effective solutions. We have a well-aligned leadership team and a highly motivated functional team to carry out our mission. We innovate and develop products with unique functional characteristics that help us serve our customers' needs better. We develop innovative business processes that help us improve our efficiency and customer experience. We have world-class infrastructure that includes an integrated R&D center and 3 manufacturing facilities that help us develop and manufacture high-quality differentiated products. Our research efforts are focused on developing nanotherapeutics, nutri-therapeutics, and cell therapeutics. Our operational presence is spread across India and 40 countries worldwide. We reach out to nearly 250,000 healthcare professionals in various specialties through our sales team of over 1,000 people and our partner sales force in various countries. At Pulse, we work with a real spirit of Pulse to bring about a positive difference in millions of lives. Because we are compassionate about people and passionate about our work.
Thanks, Alok, for playing this video. And now I hand over the academic session to Dr. Thakkar. It is over to you, Dr. Thakkar, please.
Okay, thank you. Thank you to the Pulse Pharma for this is the second consecutive program. First program we talked about general idea of the osteoporosis, and last time Dr. Tanna sir has said already that statistics that when the orthopedic surgeons are getting the patient above 70, 75, they are already osteoporotic. So we have to focus for the treatment of the fixation, at the same time prevention for the further fracture. And the 85%, that is the statistics Tanna sir has mentioned, that are not looking after this part. But today we are going for the second part, where we are discussing what are the important points for fixation of the fracture with the osteoporotic bone. So I would like to invite
and also the treatment
yeah,
of the
sir. Yes, sir.
osteoporosis. And
The treatment of the osteoporosis along with the fixation, right, sir?
Yeah.
So should we start with the of Dr. JAWAHAR JETHWA? Dr. JAWAHAR JETHWA, please share your screen and unmute yourself.
Yes, good
And
evening
we'll
good evening
discuss
to
the case,
everybody.
whatever the JAWAHAR JETHWA sir is putting here, sir.
So good evening and thank you, Pulse Pharma. What I just thought about is that for the sake of discussion, I'm having 3 cases which are not complete one, but there are some issues, and on that based, we can discuss many things, not only these particular cases, but also for other cases, how do you try to, as Dr. Tanna sir said, try to treat osteoporosis along with the fractures. So just let me start with the first one. As I said you that they are not the all...
video
Sorry?
If you stop your video, bandwidth will be good. Your voice will come better. And once you start sharing, the bandwidth will get used in.
No, it is low or
no, it's cutting. In between, it was cutting.
Okay.
Cracking.
Let us see.
It was cracking. It is not low. That is a bandwidth problem. Okay.
So
you share the screen and you start case, sir. You share the screen.
I'll have to go with first thing which comes in between. So this is not the one.
Yes, sharing has started. Now it is yes. Very good.
Okay. So now if you look at this, just a moment, let me put it in a small one.
No, the PowerPoint has gone. PowerPoint is not coming. PowerPoint is not coming. It is coming your yeah.
Now it is coming or not?
Yeah, now it is coming. Now you make it full screen.
Okay.
And now it is coming, but you have to make it power show. Just power show button.
It takes time because I can see early and then you people will get the effect little later.
Yeah. That's why we are not. And now it will come. Now it will come.
So now my point is very simple that I'm jumping over to some new modality of fracture fixation. The new modality is in the decided 2 stages. So here, if you see, this is a case where there is a very broad medullary cavity with a very bad fracture.
There is a lag. We are not able to see the case. This is the first slide. This is the first slide.
Okay. Now you can see. Okay.
Now next.
Okay, you can see this.
No, I am not at least maybe.
No, I can see the distal radius, junctional fracture, and also the proximal humerus.
Yes. That is
probably my bandwidth is low here in the hotel. Maybe the problem. Okay, no problem. You go on.
So what has happened is that such cases.
Now I can.
Sorry, can you see this?
Yes, now I can see it very well.
So these are the cases where patient has used to go on getting fractures. And as we know that after any fixation, we probably lack in advising them or emphasizing for the care of the bone as a whole. They go on getting more and more fracture. And this is the case where there was already a distal radius with also an old ulna fracture. Now he got a peri-implant fracture, and he has got a very bad.
But it is away,
and it is very bad fracture of the humerus. Now my point is very simple, that we know this humerus fracture is very difficult to catch out.
डॉक्टर जेठवा थोड़ा आपका वॉल्यूम थोड़ा बढ़ाओ.
बढ़ाओ, एक मिनट
Please.
चालू रखो, let me check it.
वॉल्यूम बढ़ाओ, वॉल्यूम बढ़ाओ आपका वॉइस का, माइक का वॉल्यूम बढ़ाओ.
We are struggling to hear you, sir.
Okay.
That may be the problem. I'm getting his voice correct. Probably is the
Okay,
problem
now
of the bandwidth. Tanna sir, are you getting voice?
No, I can hear, but as you said, he is
now
is not really loud enough.
now
Yeah,
full
we are
volume.
struggling, sir, to hear.
Is it
clearly.
full volume now?
Yeah, it's better, sir.
It is better.
Now
so I
you
have
have
put
to
it a
say-
full volume.
Now you,
Jawahar, now
Jawahar,
you
you
will have to share
imagine there
your-
is no wife of yours sitting there, so you can really talk aloud.
So now I think, or
But
what
now-
I can do is I can use the computer microphone. Let me.
Yes, sir, that
Now
would be
let me-
better. You need
can
to
hear.
move closer to it and use the computer thing.
Can you
Yes.
hear?
Now we are able to listen to you, I think.
Is it good?
At
Yes.
least I'm
Yes,
getting
sir.
his
Yes,
voice.
sir.
Yes, sir.
So this is better.
Yes.
Okay.
Yes. Yeah.
So now let me again share screen.
Acha, you stopped the sharing. Okay.
Because I wanted to check the microphone, other things. Now probably you are able to
Right.
see this. Now, can you
Yes.
see
Now
the first slide?
PowerPoint is opened, or
Can you see the first slide?
no? It's leg. No. You must be seeing, but I am not seeing because of my
No problem,
bandwidth.
but
Other
sir,
people may
can
be
you-
seeing.
can
Now
you see?
I am able to see the proximal.
Sir, you are able to see?
Tanna,
I can see that. I can see that.
Okay. So now the point is very simple. In this case, there is a very bad injury on the shoulder. So in osteoporosis, we are always facing with not only the bone quality, but also soft tissue injuries, their healing time, their waiting, as well as also sarcopenia, and also sometimes it is such a thin skin that whatever the implant you put maybe on other part of the body, they become more protruded out because skin coverage is very, sometimes it is very difficult to even take skin sutures, they are very thin skin. So all these problem for this particular case, I explained to the patient that I am going to allow malunion. And in a second stage, I am going to go for whatever the best possible fixation. Now, to allow malunion, we have got two options. One option is that we just leave it. Leaving such fractures, you might not be able to get union because it is hanging and it may remain. So some sort of a fixation is required, for which what I did is this minimal invasive flexible implant fixation for the humerus. For the radius, there was not a much of a problem because we could put a plate overlapping the other plate and we could get away very easily, and it went on very well. Now here the point is that this is the reduction which is not 100% good, but whatever is there, we wanted that it should go for a healing. Now, this is the time where we are getting for the patient to build up his bone. So patient was put on teriparatide, patient was, there was a very bad skin, but for whatever is possible, we went on. And at the end of around 5 weeks, there was some gluing because he was able to do this type of small exercise. Can you see this? With the external fixator. Now here the external fixator is very, very important. Like I have put a 2 rows of flexible implant. And there is also interconnection between the 2 rows, if you can see in the movie. Now this is very important.
Yes,
This
we
type
can
of
see.
fixation goes very well. Yes. Hello. Is there any comment?
Yes, we are listening.
Okay.
No. We are listening. We can see 2 rows. That is only given.
So what is happening is that in such cases, if you allow them to whatever is the muscle action is possible, whichever the best food he can take, and whatever the anti-osteoporotic treatment you can give. But in this case, we had started teriparatide injections and all other calcium and vitamin D3 and protein powder, and whichever the way he could do. So this was around 5 weeks. And then somewhere around 6 months, we got the union. Now, this is something which is newly coming up in the world about allowing a malunion in this way. So the point is very simple, because now probably we have allowed bone union, and that callus is better quality than the original osteoporotic bone. So now if we go with a corrective osteotomy, there are good chances that your screw and implant will hold well. And this is the principle of osteoporotic bone fractures, where you can go in the 2 stages. And this was the case where was hardly any good movement of the shoulder, and there was a lesser tuberosity near the bicipital groove, was absolutely anteriorly, and the head was more varus and also posterior. So I just finish up and we can go out with the other discussion like on such cases. Now what I did, we got the 3D model for this patient. And then we decided that if you see the first picture, this is from the posterior side. The whole head is vertically situated posteriorly. This is the anterior side, where this is the greater tuberosity, and this is afterward the lesser tuberosity, and this particular bump was subcutaneously felt. So it was very difficult for us to understand that how malunion has occurred and how to go with corrective osteotomy. So we did this simulation surgery. We tried to find out that how could we get that particular head, which was more posterior, to come back on the superior side. And this is how it has been put on superior side. And some amount of the diaphysis was cut, because unless we cut the diaphysis, this was not coming in the way. There was a mild shortening, and then the tuberosity, whichever the way we can brought it more lateral, it was more anterior. So we wanted to put more lateral. And what is the possible plate which we can put? In this case, there is a big gap posteriorly.
JAWAHAR tuberosity was anterior. Usually it goes posterior. Mostly.
Yes, that is called malunion. That is what is happening.
Okay.
These are the cases where if you are able to catch all the K-wire through the tuberosity, and by any means, if you can catch all, it's good. Otherwise, what you do is usually you pass through the insertion of the rotators. And that insertion of the rotators where you have passed, that portion is probably may not be able to catch hold of the tuberosity. It may be passing through the soft tissue more than the bone, and this is how it catches. The beautiful aspect of such fixator, which I call the minimally invasive flexible implant external fixator, MIFIX fix, that is terminology I have given. So these type of things, it is probably not only a fixation with the bone, but along with the insertion of some stout good tendons. And this will keep whatever the way you can keep the proximal fragment. Plus, it is also held by the distal wires, which goes inside whichever the place is there. And that is why this patient is able to do an active mobilization. And this is only possible because there is a dependable amount of fixation in this particular case. I mean, in a wide canal. And in wide canal, this also was not absolutely as per the principle. The principle is that these wires should go right up to the olecranon fossa. The longer this wire, the better is the fixation. Because if you put a right up to the available medullary canal, it will hold very well. And that is how it happens with the K wires, which are little thicker, because from the superior side you can pass 2.5 up to 3 mm of wires. But inferiorly, it is very difficult to pass through a oblique hole, not more than 2 mm you can pass. So that is the limitation of this. So thereafter, we tried to do this simulation sort of things, and we thought that this is the posterior side where there was a big gap. In fact, we were knowing that whatever the amount of bone we have removed from the 3D printed model was removed, but in fact, when we did the surgery, we had not removed it. We just put it, but it was pushed posteriorly. So there was no any gap left posterior side. And this is the last slide where we have just fixed it, which whatever the best position. And with this also, we thought that fixation is not very good. So we put one more anterior plate. So here my point is only to get some discussion about that there is a possibility of fixing a osteoporotic bone after malunion, because the quality of the callus is better to hold rather than. And this has I learned from the Singapore hospitals, where this at Singapore they are doing this type of practices. So I'll go with the next.
No, but Jawahar,
Yes.
in today's orthopedics, multi-lock nail with probably a bone graft onto the empty areas. Would it not be one of the alternative on day one?
Yes, it is when the soft tissues are good. When there is a very bad wounds and very big sort of a what you call ecchymosis and other problems, we not be able to get, as I told you in this case, the skin were not that good. But at the same time, sometimes there are so bad combination that even your multiple screw, you do not get that type of a good bone to have it. And so there could be a case where you can do it, but not in all the cases. In fact, this patient, I have just took the X-ray of the shoulder, but lower down, there was a full ecchymosis, anterior and posterior, right up to the middle of the arm. So,
Sir, Tanna sir, probably the Jetwa sir wants to say that these are the stressed wire under tension. They are stressed, and then they put on the external fixator, so they are holding better in osteoporotic bone. But same time, the nail in such type of fracture where it is a quite upper fracture, lower fracture than the four-part fracture, where we can possibly fix with the newer design of the nail where multi fixation is there and the screw within the screw is also possible. And that is also intramedullary fixation. And the additional bone graft, as Tanna sir has said, that is also one of the possibility. And Jetwa sir is showing another possibility. But only thing is, if the reduction was possible, that was the problem here, I think.
so
That's why it
what
was
happens that if
united.
you put an incision, go for an open reduction, you may not be able to catch hold everything. And if at all you reduce it, there won't be any space for which you can pass your plate or screw. So
No,
just
not for plate. Not for plate. Even
no,
this fixation.
even for the nail, what is very important is, if you look at very carefully, both sides wires are bent to meet each other.
I
Now,
know.
suppose if you think like these wires, if I just remove these clamps, then this wire will try to go outward. And this
Yes.
is a dynamic force.
Yes.
Jawahar,
Stress.
Yes, sir.
Jawahar, if it was possible only to treat with these wires, probably I'll accept that. But once you said you create a malunion so that there is the good bone and now go and correct it, it is a little expensive treatment which may not be agreeable all the time.
No, may not be, but that is how the newer things come up. And gradually people start thinking of or maybe selecting a proper case. But in this particular case, I was knowing that I will not be able to get a good reduction because I am not doing open reduction. So whatever the maneuver we can pass, I'll show you another case where the similar things have been done, but with a much better reduction. Yes. So if I go with the
Yes, go ahead with the second case, sir.
second case, okay, now I'll just
No,
go.
no,
Yeah.
second.
Yes, sir.
Jawahar,
Yes, sir.
even when we do a
Yeah.
multi-lock nail,
Hmm.
the reduction of the GT,
Hmm.
which is obviously an open reduction if in case it is not coming,
Hmm.
and then the contusions and everything is not really the issue if you do a nailing. If you do a philos, I can understand what you're mentioning, which is going to be a deterrent to do a philos. In any way, I think we have the things and we can go ahead with the second case.
So the second case is a conservative one, but the third one, which is very important. Well, I just finish up with the second case, where it is a question of that what is the importance of a osteoporotic treatment. This was the case where before, patient was having a transcervical fracture where I did bipolar. Patient was fine for 1.5 years, maybe 2 years, and thereafter he had another fall. And he simply told me that I have a pain in the thigh. I am able to put a weight, but not very much. I have to use walker. So I said that better you get your X-ray at your home. He is little far away from me. So he sent me this X-ray, and he said that I'll be able to. This X-ray was sent me after 3 days of fall. So he was managing something like with a walker or whatever way. Now, these are the cases, what can be done?
This is a non-cemented?
On non-cemented, yes.
So with the second four,
Probably the circlage.
The circlage, yes.
Circlage and a hook plate in order to bypass, because I think the whole prosthesis is not going way deep down. If the prosthesis is loose, then obviously changing the prosthesis will be the better option.
Right. So now I asked the patient that I had.
yes, there is no sinking sign.
Yes, that is very important. If you look at the distal part of the stem, is exactly where it was. Now, very important point is to see in the lateral view.
Yes.
Because the size of the stem, we say I pass 9 and 10 and 11, whatever the size, that size should not be checked in AP view. The size should be checked in lateral view. Because in the lateral view, there is some curvature of the proximal femur. So the stem will not be straight. Stem will be touching anteriorly distally and posteriorly proximally. Now, those type of stamp may have some gap in lateral view, proximal and distal. But when you see such cases where it is so well held, because probably the overall height is good, and second is very important point is a clinical examination where what is the history. He told me that for 3 days he is able to do deliver.
Jawaharvi, can I interrupt? You want to say that probably this is stable even after the fracture, so
Yes.
you would like to treat it conservatively.
Probably now, my point is very different. First of all, if you look at the X-ray, and with the X-ray, we do not decide treatment. Because patient was asked to go for a good anti-osteoporotic treatment, which was not done. And he said that there was nobody to take care of me or whatever. Sorry? There is a voice.
Sir is talking.
I think Jawahar.
Sir is talking.
Yes,
Jawahar.
yes.
Pre-second injury. patient no pain at all, no?
No, it is not. He said that I'm not able to put full weight, but with a walker, I'm able to go to bathroom, do all these things. On the third day, he asked the portable person to come and take the X-ray, which I had already advised him on the day one.
Jawarbi,
Yes.
Jawarbi, what we are asking is, you had operated before 3 years. This patient was
Two
operated
years.
before 3
2
years.
years.
2 years.
Hmm.
Okay, 2 years, 2 years. At that time, have you felt that this requires treatment for the osteoporosis? That
Yes.
probably we have missed it. We have missed it. And then
As,
suddenly with a very trivial injury, so that as a trivial injury, I think he got this fracture.
no, he is 76-year-old,
Or
and as sir has said, that unless proved otherwise, all patients are osteoporotic. So, and it
yes,
was a trivial
osteoporotic,
problem.
yes.
Yes. So, and if you
If
look
for
at,
the
We want
Jawahar, if for the treatment, if I
we
talk,
want
Hmm,
before he developed the second fracture,
yes,
he had no pain at all in the hip joint.
no, not at all.
So the stem is fairly well fixed.
Yes,
So I feel there is no need to do anything more. A
yes.
circular and probably a extensive
Hmm,
hook plate will be able to look after the whole thing, and he can start walking about immediately.
hmm, 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 hmm,
And obviously,
hmm, hmm.
osteoporosis treatment.
So my suggestion is that, and my understanding is that in such cases, when you look at the X-ray, we feel like that probably the proximal part of the stem is loose. Maybe distal part is still holding. But what are the clinical signs? Number one is that he is able to do daily work with some support. But very important clinical sign is active internal rotation. He was able to do active internal rotation. That is a very important sign. Then we know that it is not that much loose. Probably it is still holding well. And that is why I thought that let me give
but
another 15 days or 1 month time.
do you think that Jawarbi, if you compare both X-rays,
Hmm.
do you think there is some substance is already there?
No,
Some
If you see
substance
the
is
AP
already
view,
there. If you mark
no,
the
no,
level
no,
of
no.
yeah,
What has happened? I tell you what has happened. There is a fracture of the proximal part, which is probably migrated a little bit. That is the reason why you are able to see. If you look at very carefully the calcar
yes. So
region.
either bone has moved or the stem has moved.
Yes,
Something has moved.
yes.
There is a relationship is disturbed little bit.
Now what happens? That sometimes there is a crack which is not whole cylindrical or whole peripheral. Sometimes it is more than half, which is still catching well, which we can see on the lateral view that there is no anteroposterior displacement of this fracture.
Right.
So what I did, I just asked him that you report me every 2 weeks and thereafter every 2 months. I just asked him, and he was otherwise a very learned person. So he said that okay. And then I just gave teriparatide for 6 months, and it
It got
completely
united.
healed. Completely healed. He is now back to his normal activity. I did not do anything. My second point, sir, my asking is that in such cases, it is the only clinical sign symptoms by which we feel that yes, anti-osteoporotic treatment is working, because on X-ray, it is very difficult, particularly when you have given anti-osteoporotic treatment after fracture, whether the bones quality have better or not. So, what is your opinion on that? Tanna, sir.
say
Hmm.
it is
Tanna
only
sir,
with,
Jetwa sir.
I presume we are talking about osteoporosis treatment and bone quality.
Yes,
It is only teriparatide, which is the one which is osteogenic.
yes.
we are not talking about biphosphonates or at all. Because biphosphonates will not improve the quality of the bone. It will only slow down the deterioration.
Right.
So bisphosphonates, which we are giving it, it is a different matter altogether. But teriparatide is the one when now today, because teriparatide being every day for 2 years, probably the newer drugs which have come up, even ET, it is the one which is going to give you a far better, for a patient, it is much more easier to really give that. I don't know, I have used Divinity.
Compliance.
Which
I have
one?
used Divinity, Romozumab, as you know it very well.
Yes.
It is only once a month.
Yes.
It is only once a month for 12 months. So it's much more easier for the patient to give it. Unfortunately, the Indian brand or Indian copy of that is yet
Right.
not available.
Yes. I think it's costly.
Yes, sir. But
Yeah, it is 25,000 a
along with
month.
that, but along with that, you have to give vitamin D and calcium also.
Yeah. That is with every osteoporosis treatment, no?
Yes. It has to be. Yeah.
So one point is very simple, that the biphosphonate may increase the density, but it also increases the brittleness. So
Yes.
probably for the sake of getting a better bone, only biphosphonate is not good unless you want to prevent collapse of the sector in AVN temporarily. People are using biphosphonate to just hold it in whatever the position.
If I can quote
Yes.
one of the osteoporosis meeting, one of the stalwart of the osteoporosis treatment mentioned about that are we doing harm to the patient till now by first giving a bisphosphonates, and then if in case osteoporosis increases more, then then only we give teriparatide. He says that means by bisphosphonates, all what we are doing is we are slowing down the deterioration, but the deterioration is already there. And we are trying to protect the empty walls.
Yes.
So he has propagating it that there is no role of bisphosphonates to start with. Every patient, if you are treating it, it has to be something which is going to be it has to be teriparatide or this any of the newer things that are above the denosumab.
Yes. So point is very
Right, sir.
important point is that it is only glucose-induced osteoporosis where if you see the two phases of bone mineralization, that is osteogenesis and osteoclasis. Now, in this osteoclasis, in a glucose-induced osteoporosis, that portion is lengthened. So if you give biphosphonate, it becomes normal, not shortened, but normal. Those are the only cases where biphosphonate is absolutely indicated. All other osteoporosis, which may be old age or maybe any other reason, it is not like it will give so much of normalization of the bone. But my point was that we are also having a problem, like if we start denosumab 6 monthly or maybe Zerondilet, I mean, for every year or maybe 6 months, those cases is difficult to stop. The problem is that unless it is associated, I mean, adjuvantly we are giving teriparatide, people on only bisphosphonate is difficult to switch over or suddenly, particularly with the denosumab. Denosumab is both. It is very partly it is osteogenetic, but majority is its prevention of osteoclasis. So those cases, I have 2 or 3 patients, and one of them is my relative, where she was on denosumab for 2 years. And then after 8 months of that 2 years stoppage of that, she gave me a call that she's not able to even sit. And
No.
what happened?
JAWAHAR, now the whole literature is very, very clear.
Yes.
Once you started denosumab, it must be continued for life. If you stop it, the osteoporosis comes with a vengeance.
That is something which is probably, I don't know, how can you accept that something which is...
No, this is, I'm talking a literature, today's literature. Denusanam, otherwise don't start. If you start, you got to continue for a life.
You are right that in our city...
It is just like a marriage.
A marriage. But in our city, the spine surgeon, they are taking a consent that I understood and I'm going to take lifetime, then only they prescribe. They have started taking a consent that it will be continued for.
Consent, if they stop it, what are you going to do? You can't do anything about it. And there are so many people who are not aware of it. They say, no, abhi to 5 saal le liya, abhi band kar do.
But in this case, my comment is that whatever such treatment we are giving for osteoporosis is a temporary buying some time. It is not like patient is suffering from teriparatide deficiency syndrome. Patient is having some sort of other causes for which there is an osteoporosis. You are just helping for 1 or 2 years. Meantime, you are supposed to get back the original bone turnover by exercise, by good food, by whatever the other methods. Because just to keep the patient on teriparatide for 3 years, the moment you stop teriparatide, again it will go back if there are no other mechanism which has been triggered in the body to increase the bone stock. So probably that is also...
You cannot remain on the loan for the lifetime.
Yes, perfectly said, right. You are right.
Cannot remain on the loan for lifetime. Your capital on.
Sorry, what do you mean exactly, Navin?
Sir, I said that you cannot remain on the loan for lifetime. You have to make your capital. So by exercise or some other means, you have to build up your things with the other things. If you continue this for the lifetime, this is still the science is evolving. Who knows that the patient who has taken lifetime only gets a good result?
And that is also very important.
Because studies are only of 5 years or 6.
I'm sorry, Navin. We may agree to disagree.
Like a bedridden patient, he is bedridden, say, for many years or maybe many months. Giving teriparatide will not go on increasing the bone stock. There is a requirement of all mechanism, all musculoskeletal, all type of functions. Then only bone gets that trigger to become more stronger. So probably not much of the discussion is in the literature. Literature is thinking a lot about how many years you can give. People are now talking that up to 7 years you can give. So as the time goes on, people are increasing the limit. But there is not a good thought or study or some sort of a recommendation that how can you gradually wean over and stop teriparatide.
No. Teriparatide, anything after 2 years does not have any beneficial effect. So any continuation of the teriparatide for more than 2 years is not going to be beneficial. Only thing is, what has been now being tried out is, after the interval of about 5-6 years, you can restart the teriparatide, and that is still supposed to give a much better benefit. But continuous use of a teriparatide, I don't think anybody has recommended ever.
That is the limit, because that is the limit of probably patient as well as from the pharma company that yes, this much is the study available. But the same point is that that was a time given for which what should have been done to bring back the normal physiology and bone turnover.
No, I agree entirely when you say vitamin D, calcium, some exercises and everything, but 75-year-old can really not do much of an exercise. So some exercise is very definitely needed. No question about it.
But if you say like after 2 years there is no possibility of increasing objectively and maybe also subjectively continuing teriparatide,
Yeah,
then
continue.
No, sir is saying that there should be, sir is saying there should be, no, it should be an interval free period, and then again you have to start. Then and then it
Because
is
after 2
beneficiary.
years of
I
teriparatide,
think sir wants to.
yeah, same thing. I mean, after 2 years of teriparatide does not have any beneficial effect. But it has been shown that after 5 years of interruption, 5 years of holidays with teriparatide, because we are starting the patient with teriparatide often at the age of 60, and they'll continue to live till 80s and 90s, and they need some treatment all the time.
Yes.
That means there are some receptors which are getting inhibited after 2 years, and then when they get the free interval, they become sensitive. That receptors.
Exactly.
There must be some. Yeah.
So there may be some hormonal aspect of it, or there is no hormonal aspect.
Hormonal is only for the ladies, I think. Early premenopausal, early postmenopausal. For the men, testosterone has no effect on the osteoporosis per se.
So like HRT, which is very in a specific cases they recommend.
Yeah.
Is it so that the teriparatide can be, switch over to only HRT or something like?
Yeah, that is what HRT is, one of the option into the immediate postmenopausal women.
Yes.
But what people are afraid of is a CA breast or a bleeding, unusual bleeding and everything. Yeah. And that's the reason the HRT is probably not being as frequently used as it should have been used.
Yes. It is always the help of endocrinologist and, involving other specialty. Yes, that is true.
And I spoke to the endocrinologist. How many cases of osteoporosis do you think endocrinologists treat in a month?
I don't think very high number.
That's right. You and me see osteoporosis almost every day, 2, 3, 4.
Yes.
So we should be the one who should be treating osteoporosis. But why we pass it over to the endocrinologist?
But there's one more thing is that we are also getting patients of osteoporosis with some sort of a significant pain or fracture. But till now, I don't know in Mumbai, is it included in a whole body checkup program of going for the exam and everything?
I'll tell you, I have a special take on this.
Yes.
Whole body program in Bombay, it purely runs on the cost basis. In Jaslok, it is 2,700 or whatever XYZ, or in Lilavati, it is 2,300.
Yes.
But if you say in the ladies, they have to include these 3 tests in a ladies in a total body profile.
Yes.
One is the bone density, another is the pap smear, and another is the sonography of the breast.
Yes.
These 3 things which has to be included. So they always put it down, they advise. This is advisable to you, and that will be extra charge XYZ. Otherwise, the total mobile profile is only 2,200.
Right.
So I think that this all the whole body checkup, total body checkup is a commercial aspect to keep their staff busy, those who are not working.
Absolutely.
All machines working or not.
So they are not really hard to find out which are the patients with those. It's a commercial part, I think so.
Yes.
And it has become commercial for the hospital, because when I spoke to the hospital management, You know, it's a big money spinner. There is no question about it.
Yes. Yes, because the patients think that my body has been checked completely. Now
Everything has
body
been
checkup
checked
is
up.
done. Everything is okay.
And then they also say,
Right.
you will have one physician, one orthopedic surgeon, or one skin specialist, or somebody, two consultants will see you. So whoever are there on the call, they send the patient there.
And my second question is that in my life I got 2-3 patients, but the one patient I remember very well. It was minus 6.5 DIXA.
Yeah.
When he was hardly able to sit on the examination table, he said that give me something so that I can sleep as fast as possible. Now, those cases, otherwise there was no only backache, there was no compression of anything. But when I asked him for DIXA, there was a call from radiologist. He said that this is very high osteoporosis. So how the lowest reading have you in your practice?
5.8.
Oh,
5.8 I have seen.
and what was the clinical presentation?
And that's all aches and pains all over. And they are the ones who say you put them on teriparatide, and
Yes.
after 6 months they come say, "Saab, aapne to jadoo kar diya."
Ah.
If by chance they get a fracture, then it's a different thing altogether.
So those are the patients who are also avoiding trivial trauma.
Yeah.
Anyways, as I just go through the third one, which is a very small one. So this is a fracture where probably when we are with the era of this 3D CT scan, we know that there are multiple fragments. As such, CT scan will always show more fragments than what we see in X-ray. But anyway, when we see like this, we probably have to think of multiple way. How can we fix this with such a fracture? And also you can see in the CT slice something which is over added and also like this. So what we did is the same thing, particular spin correction. But very important point which I just want to give as a technical aspect of such fracture fixation is that if you look at the first one which I have written down as a pin to correct varus. Now this pin is having a lever not necessarily over the bone. The lever point is on the insertion of the rotator cuff. So it is a rotator cuff which is one. Otherwise, this greater reversibility will just collapse. You cannot do that much of leverage. And second is the medial side just below the head fragment, so that you can lift it very well. So this was the case. Now, second is very important. The second in the lateral view, if you look very carefully, is to correct the posterior angulation. Now, this I learned a lot in 2-3 cases that so many times we miss that the head is not only in varus, but it is posterior. So something which you have to pass just on the lateral border of the bicipital groove, try to go posteriorly and then try to elevate, and you will be able to see a good reconstruction of the head because now it is tilted from posterior to the superior side. And this is how in this case, with this maneuver, we could get fairly good reduction. And another point which already Navin has in some conference has noted, that Japanese people say that you do a primary docking, primary impaction of the distal fragment. And I think that is also very important, which I have done in this case, that the calcar I have not tried to reconstruct calcar. Rather than I have allowed the diaphysis to go, the metaphyseal region to go more into the head and get some internal stability. Second point is that in this particular procedure, when we pass to more than 2.5 or 3 mm K-wire from proximal side, it is difficult to bend at the point where we want. Because usually we bend it and the bending would be just superior to the acromion process and it will come with some sort of a shoulder movement. Of course, we cannot get a full abduction, but whatever the shoulder movement you can do, if you do not bend it right at the entry point of the head region, it will be difficult. So what I have found out is using a metallic suction cannula. That metallic suction cannula can go right up to the point where it is inserted into the bone, and then we can very well band it much proximal. Otherwise, it could have been at the acromion level, and this is how it was fixed. If you can see, and this is how it is seen clinically. Now here again, all those wires which are fixed and distally there are 3 wires. So there are multiple clamps. There are also cross bars. So cross bars increases the stability of the total construct, which is very important. And this is just, I wanted to say this is one of the methods of fixing osteoporotic fractures. We have now series of cases and we do not get a complete abduction, but we get almost around short of 30-degree abduction. I mean, much above the 90-degree, 100, 110, 120-degree, but not beyond that in any of these cases where we have treated. But the only advantage of this method is that you are not injuring the rotator cuff too much, which you might do in passing nails. And thus,
No, I think,
Mm.
एक second.
Yes, sir.
Nail is passed through the humerus head rather than the junction which we used to pass in past. Today's
Yes.
multifocal nail is in line with the medullary cavity, so it passes through the head and it is sunk inside.
Yes.
So it is not at the junction of the tuberosity and the cuff.
No, that also true, but what happens that we have to cut the rotator and we have to repair it back.
No. Just it is a puncture and you just go in.
No, that means, I mean, 7 mm, 8 mm of nail, which you pass through the rotator cuff, is sufficient injury to the rotator cuff.
You won't be able to stitch it up because you are passing a
No,
reaper
what,
and you are passing a guide wire and a nail.
no. What we do, we put around a 3 to 3.5 centimeter incision. We explore the rotator cuff. We take a sutures before cutting the rotator cuff. So there are stay sutures there. And then we put something to protect and then we start all this nailing. So that all these sutures which has been taken before can be just tied up. Because that is a really big damage to the rotator cuff. Although you are sinking back, so maybe you are sacrificing some part of the articular cartilage, but it doesn't matter much in a non-weight bearing bone. So that way.
Today,
Mm.
I think in quite a few circles,
Mm.
Veloz has been completely replaced by the multi-lock nails.
Mm-hmm. But maybe we have to, I mean, all these patients, ultimately, whatever you do, it is very difficult to get full abduction.
Now, that is true.
True. It's difficult to get.
Full abduction, you will get it only in a comparatively youngest patient, you don't put a Veloz, but you put only multiple K wires, what you are showing, then there is a good chance of getting a full abduction.
Yes.
I've been showing those cases where you put only 2 or 3 screws or 2 or 3 K wires, and I don't really connect them the way you are connecting it. I really bend them and keep them inside the skin so that you can just go down and really take them out. And it has to be threaded one, otherwise it has been observed that it may really migrate way high up.
Yes.
So it is the threaded wires which are remaining there, and underneath the skin they are bent and they are kept there, so that it's much easier to take it out.
So the only advantage is that the wire which you are passing from the superior side which is probably not holding any bone. It is, as I told you, at the junction of the rotator cuff insertion, but they are going right up to the distal part of the bone, which is a very good lever arm for the final fixation. So when we
That what I
No.
that what I do is like a J wire of a chandak.
Yes,
I
yes.
go there and put them onto two directions into the head.
Yeah. But that also is, he starts from the middle of the humerus.
Yeah, we start from the middle of the humerus.
And then there are multiple wires which we have to make a hole in the humerus on lateral side is also difficult, and technically we have to be very careful that it does not create a transverse fracture. So you have to be very careful in making
No,
those.
no, Jawahar, it doesn't. I've done enough of it. It
Mhm.
doesn't create that. Only thing is you have to drill it, oblique drills,
Yes.
and you have to pass that.
Yes, yes, yes.
Basically, you need two wires there, one going medially, one going laterally.
Mhm.
And along with those the same wires which you have done it.
Mhm. So my
And
point was that have you come across in the literature or in the books that what is the biomechanical change when you connect them outside, not by putting a additional rod, which we usually put like we put a rod and then we fix with a clamp. There is a difference between the way I have done and putting a rod, because this is something where there is a continuation of the K wire which each other they are blocked. So there is a elastic recoil and flexibility of this flexible implant which works and to create a micro motion. In all other external fixator, we put something like a Shan screw. Or if we are at all going to put, then we put a thick rod to connect both of them. And here I have found that there is a much different types of forces which are working. And I'm very happy with the distal radius in a similar fashion that we are not passing bicortical and putting externally fixation. We are passing one which is right up to the head of the radius. But once we fix them externally, they create a construct which is similar to, if you know, that there is a tool for rearranging the what you call the railway line, uh, uh, those stones. They have this type of a tool which will be able to they can rearrange very well without distorting the tool. And that is similar way when we fix it like this, it induces extraordinary stability, but at the same time, it is not rigidity. It is something like a movable, but yet very well catching hold of the reduction. So, and
I
I
think
also have found that.
probably
Hmm.
some 20 cases like this and 20 cases like the K wires, which quite a lot of us do it.
Hmm.
And we compare whether how much is the loss of reduction,
Hmm.
then we may be able to really save much about it.
Yes. And secondly, one clamp is not enough. One clamp is a one point. So I have found that those cases where I used to pass only one clamp, it was not giving a good stability. Once you put a two clamp, which is at least 2 centimeters apart, then it is a wide area which has been fixed. And not only it fixes the fracture well, but it also reduces the chances of pin track infection. That is also I have observed.
Okay.
Right, sir.
I think now it is already 9:15.
Yes, sir.
Anybody has any questions? I think you have any questions do you get from the audience? Do you want to say anything about it?
Sir,
And
I'm just
probably-
checking. Sir, I'm just checking for the questions. Nothing coming from audience. FD, Alok, did we get anything from the audience? Sir, I have a question. We have been talking briefly about denosumab and terapeutide in between. When we brought in the medical management. So I was wondering, yes, vitamin D and calcium are important, and they are important cornerstones.
Many, I think they are very, very important because we find vitamin D
Hmm.
low in about 80 to 90% of the people, or at least 70% definitely. So vitamin D substitution is one of the most important part. So calcium and vitamin D is a part and parcel of osteoporosis treatment.
Yes, sir, they are cornerstones. What I was wondering, sir, now since more focus is on injectable medication, right? Now that means we need to build up vitamin D levels very rapidly. So there is no lag. The medication start working in the absence of vitamin D. There would not be much of calcium. So when I compare oral drugs, with the IM injection, which was much in vogue, I don't know how much it is still is.
Now,
I
I
really,
feel that there is enough evidence to suggest that intramuscular is not any better than oral.
in fact, sir, contrary to that, I have seen studies and we have done some work, sir. I realized that the oral ones, they are doing a better job,
Anytime.
than the intramuscular ones. Maybe
Because
because of what?
intramuscular ones goes inside the muscles,
Huh.
and it may not be absorbed so rapidly as the oral one which gets absorbed.
Yeah, it's
So
almost
I
like
have completely given up intramuscular vitamin D.
yeah, yeah. That was what I was trying to understand, sir, and especially with the injectable ones, it is more worthwhile, anyways.
No.
Uh,
So I think either oral tablet form, or the whatever the Daxel which you people have, which is one of the excellent ones.
yeah,
I think it is the one which works very well
yes,
every
sir.
weekly for 8 weeks. It is the standard way in which, in case you. But the majority of the people, what do they mistake is they treat vitamin D once, they get the levels, and they forget about it, but which is not true.
Yes,
Because I think the vitamin D, once it comes back to normal, again gradually it goes down, because I think whatever either food or vitamin D from the sunlight or whatever it is not enough for us all the time. So
yes, sir.
my random treatment is vitamin D orally once a week for 8 weeks, and take it every year once a week for 8 weeks.
Sir,
Though it is random, but I think that this is what is required.
So,
sir,
Dr. Harsh, I have a question for you.
yes, sir.
Like you, from the beginning, I have noted that you go into great detail of all this physiology and what is happening in the body. Have you come across any information that vitamin D is directly being consumed by the body cell, or it is always when it is converted to 125 hydroxy? So, have you come across any such information? Because I have now started all those effort class people to go for both level together, 25 hydroxy as well as 125 hydroxy. Now, 125 hydroxy is a very costly one.
125, it
Hmm.
has been recorded
Yes.
that ordinary vitamin D3 is converted to 125 in a normal human being, except the ones which have a kidney problem.
Hmm.
So only those which have been having a high urea, they
Hmm.
are the ones which you have to give them that ferrol 125. Otherwise, an ordinary vitamin D is going to be as good.
No, my point is different. My point
I'll,
is that which is used by the body. By
sir,
the body, it is used 125, right?
yes,
Why do we bother for the level of 25?
I'll come to that, sir. The
My point is
problem is, sir,
my point is very simple.
now I'm coming to that, sir. I've understood your question, sir.
Now what I have done, I
Hmm.
have tried to compare that if vitamin D3 is low, is it so that 125 is also low? Up till now, I have gone only for 3 cases. Two of them, it was not the case. Vitamin D was very low at 125 or absolutely not.
Mm-hmm.
So my argument
One
is like,
minute.
let me give an analogy. Something like somebody is there and I say, oh, you have such a low sucrose level. You better get admitted and start your drip. Then he said, Baba, I don't want a good sucrose level. I need a glucose level.
Glucose levels.
Glucose is being used.
Yes.
So whatever is the case of sucrose, I am not very much worried about it, whether it is there or whatever. So ultimately, 25 hydroxy, which we are looking at the level so high,
Hmm.
I could not find any publication where there is a parallel investigation of 25 with 125 before treatment, after treatment, before symptoms, after symptoms. I don't know if you have come across that.
Uh, Sir, I have not come across, but I would like to respond in this manner. One foremost thing is, sir, we synthesize and generally we utilize cholecalciferol, right, which is vitamin D, as simple, right? Ergo or choline, whatever, D2 or D3. Now, this is something which is inactive. It has to undergo two hydroxylation processes, first in the liver to get converted to 25 hydroxy, and finally the alpha hydroxylation in the kidney to get converted to 125 dihydroxy. Right? Now, the receptors which are present, which we call the vitamin D receptors, which are present in each and every cell in the nuclei, you know, they recognize 125 dihydroxycholecalciferol as the active moiety.
Yes.
Right? So they recognize that as a active moiety. Now, it so happens that when we are talking about the deficiency of vitamin D, right, our marker is 25 hydroxy, which is only a partially activated thing, right? That is your question, basic question.
Yes.
Here is the issue, sir, that 125 dihydroxy has an extremely short half-life. It is only about few hours, right? Whereas if you look at 25 hydroxy, we have a half-life of about 15 to 21 days, which is adequate to understand the treatment. And if I talk about cholecalciferol, it has much longer. You know, so what has been done, 25 hydroxy has been taken as a marker. And when we talk about the level of adequacy, which is come as 30 or 35, sir, so that is keeping in view that it just keeps about the PTH within the check, within maybe 20 and 70, that kind of a thing. So even that level is today being questioned, is it adequate? Because if you look at many studies, you will see that to accrue any neuroendocrine benefits, you need about 60 nanogram per ml. In less than that, it will not work, right? If you want attack any inflammatory drug, autoimmune condition, right? Like you are talking about psoriasis or maybe some other thing, you know, where vitamin D is frequently used. It is, you are looking at a level of 75 to 80 nanogram per ml. Otherwise, it will not work.
So in this connection, I have been told in the discussion of AdBoard and so many other companies.
Yes, sir.
That when we take vitamin D3 tablet, then there is always a physiological mechanism that how much to absorb in the intestine. So absorption depends on 25 hydroxy level rather than 125 hydroxy level. So that is the argument was given that because body senses out that how much is lacking, so body checks not 125 level, body checks 25 level, and then accordingly whatever is a deficiency, it goes on absorbing when you are giving the tablet form or liquid form, whatever. Now this again creates a doubt that means that 125, as you said, may be a short life, but it is always maintained by the body, which is ultimately the useful molecule. Maybe with whatever I can do now in couple of months, I will be able to find out that what goes parallel. Is there any role of, you know, considering both levels together about 125 as well as 25. And one more thing is that none of the pathologists have told me that 125 is difficult to measure. They are able to measure very easily. But as you said, if the time is very short, then in those cases you might get a varied levels during the day. Maybe sometimes very high, sometimes very low. I don't know.
It's sir, 125 hydroxy estimation is very expensive. I'll tell you, right? Now, what has happened? How do I know, sir? I'm just on the verge of initiating a clinical trial in patients with secondary hyperparathyroidism who have grade 2 to grade 5 CKD. Right? Now, I am estimating 25 hydroxy also and 125 hydroxy also, plus the FGF 23.
Very interesting. Very interesting.
Yes. So maybe it will take me about 6 to 8 months to complete this work. I have about 70 patients lined up for this thing.
I think we had a very good discussion on this, right?
Yes.
Good.
So that will be able to throw much more light. Second thing is, sir, whether your body synthesizes vitamin D or you are taking cholecalciferol from outside, right? Whatever, there is a variable absorption, whatever you absorb, depending on your current level of 25 hydroxy, because the blood levels are 25 hydroxy, you know, what is deficient is getting converted. Rest is getting into the adipose tissue.
I think you are right that more the research and more of these of a query will bring us more knowledge.
Sir.
Good. Yes, sir. Tanna, sir.
Yeah, I'm listening.
Oh,
I don't know how much I was right, but it's so. And we are doing some work, sir, utilizing very high doses also in psoriasis also. Something called a Coimbra protocol. We are using 30,000 IU every day for 6 months.
So Tanna, sir, I was having the similar sort of a asking in some of the meetings that we have 1.4 kilogram of calcium in our body. How the hell calcium ion is getting less? The blood calcium ion. That it is such a micro of the total calcium of the body. Can there be any time deficiency of calcium level in the blood? And there are multiple answers which I am getting from various experts. But logically thinking that body has so much of calcium, how there can be a calcium ion deficiency? But both of these mechanism, calcium ion and calcium in the bone, probably are having a separate cycles. Probably they are not connected, maybe.
For practical purpose,
Yes.
vitamin D3, 60,000 once a week. Is that enough for 8 weeks or is not enough according to you?
No. For the pulse, particularly, I prescribe 10 because it is available in a pack of 5. So I said it take 2 for a pack. So for 10, it is for 10 weeks and then once a month. But I don't know, there could be sometimes something will come up, well, it will be more than 60,000 and patient might have to take once in 6 months or whatever. But at the same time, 60,000 per week is enough only when it is above 10. If it is below 10, Dr. Harsh can correct me. If it is below 10, then we might have to give every 2 or 3 days or maybe a pulse like every day. Is it so, Dr. Harsh?
Sir, yes, we have done some work with the Nizam's Institute, sir. And what we have seen is if you give 60,000 every day for 10 days, so a total dose of 6 lakhs, you are able to maintain the level somewhere, adequacy level somewhere between 6 to 9 months. Right. So then you can repeat at the 9-month level or closer to a year, whatever, because a lot of what we achieve depends on the BMI of the individual also. With the higher side individuals, you know, you achieve lower levels and your doses would be greater, much greater than the leaner individuals who achieve the levels much faster. So that is there. But the fact of the matter remains, irrespective of the dose you use, you'll have to maintain it, whether by additional weekly supplement or 1,000 or 2,000 IU daily or whatever you decide to do, sir.
Today, majority of the calcium has about 2,000 vitamin D3.
Yes, sir.
In that.
Yes.
So do you need anything extra? Because I think according to some of those endocrinologists, they say 2,000 to be taken every day
Hmm.
is the far better option than a 60,000 taken every week, only for 8 weeks.
Sir, by taking 2000 every day, right? Uh, it depends on the outlook, because you are taking longer to correct the deficiency if it exists.
Yes, it is
Yep.
maintenance. It is
Yes.
maintenance.
So when you are starting, let's say when you mentioned, or Dr. Jethwa mentioned derazumab or teriparatide or so on, you will take much longer. It would not be. So the ideal thing is use a short-term high-dose therapy probably, and then maintain it with 2000 I. I think probably, sir. This is my theoretical knowledge, but then that is what I believe is the correct thing. Sir,
So, one more problem we are facing is, Dr. Harsh,
sir,
when we put patients on teriparatide,
sir.
is once in a month I get a call, or when I inquire, I ask the patient that how the things are going. Yeah, absolutely fine. I'm daily taking injection. Then I ask them that, do you take calcium and vitamin D3, which I have given as a combined sort of a formulation where there is also calcium plus 2000 of vitamin D3. He said, no, 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 no. I don't take that because it gives me constipation. So I am taking calcium with the form of this teriparatide injection. They do not know that only teriparatide without consuming calcium or D3 is going to have a reliable or good effectiveness. So in my question is that how many patients, sir, you have come across where patient has forgotten to take calcium, they simply go on taking teriparatide, and then you come to know in your follow-up.
Have you seen anyone
Hmm.
with the teriparatide properly taken for 2 years or 1.5 years, whatever you believe in,
Hmm.
have not improved whether they have taken calcium or not calcium?
No, that is why there was a good comment from one of the expert. He said, in those cases, the normal diet is enough to pick up whatever the calcium is required. But maybe if D3 is not given, it is not going, this diet is not sufficient. So I don't know that are we getting satisfied at the end of 2 years because of the DEXA levels have become normal, and that is what we are satisfied with, or that.
Ek second. Have you ever seen a normal DEXA level after teriparatide?
No,
Never they become normal.
never they become absolutely true, even after 2 years.
But if I can ask you a corollary,
Yes,
if it was minus 3.8
yes.
and it has become -1,
Hmm.
what is your conclusion?
I mean, it is better. It is better, but then it is always the
No.
patient.
Ek minute, Jawahar.
Yes,
I am asking you the question.
yes.
विचार करीन जवाब दे.
Hmm.
Ever in an osteoporotic patient,
Hmm.
minus 3.5 has become ever minus 2.1?
I mean,
Never.
no, that is you are right, but if at all it improves, improvement means minus would be less minus, then it will tending to zero. That is what is an improvement.
No. I'll tell you. I have this repeatedly. My observation is
Yes.
my diagnosis of osteoporosis was wrong based on
Hmm.
DEXA.
Yes.
It was a pure osteomalacia.
Oh, you are talking of that. Yes.
If it is a pure osteomalacia also,
Hmm.
DEXA can be minus 3.5, minus 4.
Hmm.
And he was so dramatically happy about it. He was a super executive. डॉक्टर साहब आपने तो कमाल कर दिया, किसी का नहीं हुआ ये -1, आपने तो -1 कर दिया. I mean, how can I tell him that my diagnosis was wrong? You only had osteomalacia, so the calcium vitamin D thing has worked. Teriparatide, you didn't need it.
Right. That is very true that regarding osteomalacia versus osteopenia, we have this confusion, and that is one more thing is that endocrinology point of view, thyroid, parathyroid, other things, I mean, particularly parathyroid, which you have to be very careful before just depending on teriparatide. He might be requiring a good correction of the
So
osteomalacia.
every patient whom I investigate for osteoporosis,
Yes.
I ask for vitamin D3 level, serum calcium, phosphorus, and magnesium level.
Magnesium, how much do you get?
I don't remember the standard, but if it is less, 200 milligrams of magnesium per day is going to be very helpful for this bone formation. Phosphorus, we are all are aware of. Occasionally, even the phosphorus is less. So, hypophosphatemia, that also you'll have to improve upon. So, this along with vitamin D and the calcium, these things also needs to be supplemented if in case they are less. And unless you do the investigations, you will never be able to find it.
Right.
And PTH, obviously PTH. Most important is the PTH. If the PTH is raised, don't start with the teriparatide. Start only vitamin D and calcium. See how the PTH has become. Do the DEXA again. If the DEXA is improved, that means the only PTH which was there, which was the cause, was the osteomalacia, and you don't need osteoporosis treatment. Though hardly ever it happens in elderly, but in a comparatively youngish, say about 50 men, occasionally you will see this.
So if you give a formulation which contains all of this, magnesium and vitamin D3 and calcium and whatever, folic and everything, and you might not have discriminated, or might not have gone into DD, like it is osteomalacia primarily or it is osteopenia. And if you start with teriparatide, is it so that maybe both are taken care of because you have combined everything
No, but
together?
if the PTH is high, then you are not allowed to start the teriparatide.
Yes.
PTH has to come back to normal. Then only you can do teriparatide.
That is true. There is so many patients we see with multiple fracture, and then create more doubt that how come there are ramus fracture and other fractures, so there might be something wrong.
Exactly.
Yes.
They are all osteomalacia. Okay, thank you very much.
Thank you so much, sir.
Thank you.
No more questions. I think everything has been taken care of. Thank you so much, sir, for enlightening us on the subject. And we have all been able to learn so much more today. Thank you very much.
Bye-bye.
Thank you so much, Dr. Jethwa.
Thank you very much.
I think Dr. Thakkar has left earlier. His connection was a problem. Thank you so very much, sir. Thanks a lot.
Bye.
Thank you.
Thank you, sir. Good night.
Good night. Good night.